Okay. Did it tell people that I'm recording? Cool. Bro. So let's start with a quick round of introduction, shall we? For those that haven't met me before, I'm Adam. I'm the Patient Involvement Officer for Brains Trust. I organise this sort of thing, discussion around research, clinical trials, alternative treatments, and things like that. I'll just go around my screen and just call on people to just say a couple of words about who they are and why they're here, if that's okay. So I'll start with Joe.
I'm Joe Lloyd, and I've got a GBM stage 4, and I'm just here to find out what the alternatives are, really.
Oh, thank you, Joe. Richard.
Hi everyone, I'm Richard. I'm recovering from treatment for GBM, so being monitored now, but very interested in what's coming forward in the case of a recurrence.
Thank you, Richard. Ian.
Hi, Ian Clark. I was diagnosed with HBM at the end of May this year, and I'm following the normal NHS standard treatment process.
Thank you, Ian. And Sophie.
My partner Greg, he was diagnosed with a grade 3/4 astrocytoma a year and a half ago, and finished standard of care for now.
Thanks for joining, Sophie. Hester.
Hi, I'm Hester Franks. I'm a medical oncologist. I'm going to hopefully be one of Daniele's PhD supervisors if he's successful in getting the funding he's applying for.
Well, thank you. Lovely to meet you. Tom.
Yeah, I'm Tom O'Kane. My wife has a glioblastoma. I'm also a vice chair of a research ethics committee, so I'm very interested in research anyhow.
Well, thank you, Tom. Helen.
Hi, Helen Baker, patient GBM4, but also involved in quite a few PPI groups, different Hull Uni, this one, and I'm a volunteer for brain tumour support as well.
You say yes to everything, Helen.
To my detriment
nice to
times.
Yeah, it's nice to see you again.
You too.
Carrie?
Hi, my name's Carrie Thompson. I'm here because I'm interested in GBM. My brother died last year of it, so I just want to see what's going on and just keep abreast of it and educate myself and other people.
Thanks so much, Carrie. Nick?
I'm Nikolai. I was diagnosed with brain cancer, oligodendromadroma or something like that, grade 3, and I had the surgery, I had the radio and chemo, and now I'm interested in what the people are doing, how they live their life, because I don't know how to manage in the future.
Yeah, thank you for joining, Nick.
Thank you.
Ben?
Hi, I'm Ben, again, grade 4, diagnosed in April, May of this year, going through the treatment. Yeah, just want to find out more and connect with people. Thank you.
Thank you, Ben. Vicky?
Hi there. I'm a mum. My son Ben, he's 24 and was diagnosed in October 22 with an inoperable gloma on his thalamus. So he's had the standard, but we're getting towards a year of no treatment now, still with stable scans, but it's not gone away, it's still there. So it's that kind of time where every scan is nerve-wracking.
Mm-hmm. Thank you for joining, Vicky. Grant?
I'm Scott Snowbot. I'm a GBM4 patient and coming up for 3 years.
Thanks, Grant. Nice to see you again. Susan?
Hello, I'm here. My daughter was diagnosed 2 years ago with a grade 4 glioblastoma. She had awake surgery, radio, chemo. Chemo finished. She did have chemo for a year, and the chemo finished in June, and she's now on 2 monthly scans.
Thanks for sharing, Susan. Sarah?
Yep, hiya. Dialing in because I am the wife. My husband has glioblastoma stage 4, methylated, so with a bit of hope, but dialing in just to try and find out as much as possible, really.
Well, thank you, Sarah. And Denise?
Hiya, my husband had a glioblastoma removed in May of 2019. 5 years, so this 5 years to the date, in May this year, he's had a reoccurrence. So he's back on the chemotherapy.
Right. Thank you, Denise. And Heather?
Hi. Yeah, I'm diagnosed stage 4 glioblastoma. Diagnosed just coming up to my year anniversary of my surgery, partial remover, and my year's chemo will be up in January. Just here to find out a bit more.
Thanks for sharing, Heather. I think that's everyone. So I think before I allow Daniel to introduce himself and talk about the topic, I'll just ask that while Daniel's speaking, we just remain muted throughout that, and then afterwards we can start to have some discussion around things. You know, Daniel suggested like just kind of like shouting out and asking questions throughout, but there's so many of us that he might not get through a sentence because we'd all just want to keep asking him things. So I think we'll probably hold it till the end in this case. So I'll hand over to you now, Daniel, if that's okay.
Thank you. Thank you. My name is Daniel Scotto. I'm a doctor based in Nottingham, currently specializing in oncology. And last year, I have an interest in brain tumors. And last year, I did a small pilot study on glioblastoma, specifically the immune cells that surround the tumor, and now I'm applying for a PhD to hopefully continue my research on high-grade brain tumors. And what I'll do today is I'll give an overview of what the current standard of care is, which I'm sure a lot of you already know that, so some of this will be going over things that you know very well. And then I'll also talk about alternative treatments that are out there, and I'll touch upon the current research in glioblastoma, what the main themes are, what the sort of research community is looking at to try to find new treatments for this cancer. I would like to, first of all, thank you all for joining this meeting, for giving me your time. I'd like to say I'm very, very interested in learning about you, about your personal stories, about your opinions and experience. So after my talk, I'd be very interested in learning about you, and then thank you so much for being here. So I'll start by sharing my screens, and Adam, let me know if you can see my my presentation slides. I will hopefully, I'm not sure if you can you see that the slides?
That's perfect. Yeah.
Perfect. All right. So today what I'll cover, as I said, is the standard of care in glioblastoma, the alternative treatments that are out there. I'll briefly try to explain what the barriers to successful treatments are at the moment, what makes glioblastoma so difficult to treat, and what are the barriers that researchers have to deal with right now. And I will summarize what the themes of the current research in glioblastoma are, both research that is targeting at looking at the tumor itself, and research that is looking at the environment within and around the tumor. So As you all probably know, glioblastoma is the most frequent malignant primary brain tumor. What that means is by primary is it's a tumor that arises within the brain, unlike other cancers that arise elsewhere and then spread to the brain. For reasons that we don't fully understand, it is an increasingly common diagnosis in the UK, but also in other countries. And this does not apply to other brain tumors. Glioblastoma seems to be, its incidence seems to be rising more than other tumors. However, it is still considered a relatively rare type of cancer compared to other cancers like breast, lung. At the moment, the standard of care has three key components, which are surgery, first of all, surgery, and then radiotherapy and chemotherapy with a drug called temozolomide. This is the current standard of care for glioblastoma in the UK. So at diagnosis, if the treatment is operable, the patient, usually the first step is a maximal safe surgical removal. If the patient is fit to have chemotherapy, and they will start what's known as concurrent radiotherapy with temozolomide chemotherapy. What that means is having radiotherapy with temozolomide at the same time. And this is basically 6 weeks of radiotherapy with temozolomide, which is a pill taken every day without interruptions during that period of time. That is then followed by maintenance temozolomide, which is temozolomide on its own, and that's given in cycles. In other words, 5 days of temozolomide once a day for 5 days, followed by 23 days off. And each cycle of 5 days and 23 days off the treatment is called a cycle, and the aim is usually to do at least 6 months of temozolomide maintenance chemotherapy. At that point, the patient is monitored for any growth or recurrence of the tumor, and if the tumor comes back, the options at that point are either going on alternative chemotherapies, such as lomustine and something called PCV, which is a combination of different chemotherapy drugs, or in some cases, for patients who have shown a very good response to temozolomide, usually patients who during those 6 months of maintenance temozolomide, their cancer has responded really well to that treatment, and then it started growing again after stopping that, they can have a re-challenge of the temozolomide, so they can go back to temozolomide, and sometimes that helps. The other sort of arm of the treatment pathway is for those patients who are not fit to have chemotherapy, is to have radiotherapy alone. That also usually lasts about 6 weeks, and then the patient is monitored, and if the cancer comes back and they are fit enough to have chemotherapy at that point, they may have one of the drugs that I mentioned, temozolomide, lomustine, or the drug combination PCV. Usually, temozolomide being the first one that is tried. So this is just a quick summary of what patients have in the UK right now. This treatment pathway may not be, so each patient is slightly different for many, many reasons. So this does not necessarily apply to every patient, but in general, this is what the treatment pathway looks like in the UK and what the NHS offers. So, as I mentioned, the first step is surgery. And the way surgery works is by using a technique called fluorescence-guided neurosurgical resection, where the patients are made to, they're asked to drink a substance, which is a dye prior to surgery. The dye is in an inactive state at that point, so it does not give off any light. And when that dye is ingested, it's absorbed into the blood, and it reaches the brain, and cancer cells have the ability to chemically change that dye. So basically, it turns that chemical reaction that happens in cancer cells, turns the dye on, and makes the cells glow pink under ultraviolet light. So during surgery, the surgeon shines ultraviolet light in the surgical field that makes the tumor cells glow pink, and that helps remove as many tumor cells as possible. And this technique has been quite a breakthrough in the management of glioblastoma, because it's been shown to increase significant amount of cancer that can be removed, and it has been shown to improve survival after surgery. So unfortunately, though, as I mentioned earlier, not everyone is eligible for surgery, and whether or not someone is eligible for surgery depends on a few things. The first thing is the location of the tumor. So sometimes the tumor may not be operable because it is located in a region of the brain that cannot be safely reached, or which is too close to vital areas of the brain, and therefore the tumor is deemed inoperable. Another element which can affect surgery, although it is not necessarily a contraindication, is the size of the tumor. So usually what the literature says, what most surgeons say, is that a tumor that has a volume of 30 mLs or more is almost impossible to fully remove. So those tumors may be partially removed, but if it is that large, it's usually not, removing the entire tumor is usually not a feasible option. Finally, the patient, of course, is a very important, if not the most important factor here. Not surgery this is a high-risk surgery, and as not every patient will be fit enough to have this surgery. So that's also something to keep in mind. Because of all of these factors, the estimates vary in the literature, but it is said that between 16 and 40% of patients are not operable at diagnosis. So quite a large, a significant number of patients, unfortunately, do not have a tumor that is operable when they are diagnosed with glioblastoma. So very briefly, how does radiotherapy work? Radiotherapy is basically a high energy beam that is aimed at the tumor, and that energy causes small breaks in the DNA of tumor cells, that causes cancer cells to die. Unlike chemotherapy, radiotherapy is a local treatment, and what that means is that it targets the tumor area and the cells near the tumor only. Because radiotherapy is a localized treatment, it generally has fewer side effects than chemotherapy. However, it's because we are talking about the brain, which is a very important area, and we are directing a very high energy beam at the brain, it will have some side effects. And the early side effects, these are they happen during chemotherapy, or during radiotherapy, during those 6 weeks, or in the period immediately after those 6 weeks. These are the most common are fatigue, hair loss, nausea, skin irritation, visual changes, headaches, and seizures. Seizures is probably the most important of these. And the reason why radiotherapy can cause seizures, or can make you at a greater risk of seizures, is because the damage to the cancer causes inflammation, which causes brain swelling, and brain swelling can trigger seizures. So that's probably the more kind of significant early side effect of radiotherapy. These early side effects are usually completely reversible, and they will disappear within 6 to 12 weeks after radiotherapy has finished. So generally, these go away within sort of three months after radiotherapy. Later side effects they are mainly cognitive side effects. So they are side effects such that have to do with some memory loss or difficulty concentrating, difficulty planning, and these are usually not fully reversible, although they may improve with time. In more rarely, if radiotherapy is given close to the eye, it can cause cataracts. These can arise even years after the radiotherapy, but they are usually they're treated with a very small operation. They're quite relatively easy to fix. And more rarely, because the brain doesn't just control thought and the nerves, it also has parts of the brain also control our hormones. They control the hormones that are released into the blood. Radiotherapy, in some cases, although rarely, can cause hormonal changes in the long term as well. However, keeping all of this in mind, in the vast majority of patients, radiotherapy, the benefits of radiotherapy, they far outweigh the risks of treatment in most cases. Temozolomide. So temozolomide is a chemotherapeutic drug that was developed was introduced in the late 90s, and it was quite a breakthrough because it was it was the first chemotherapy to really make a difference in glioblastoma. And what it does is, unlike radiotherapy that damages the DNA of cancer cells using high energy, temozolomide does a similar thing. It still damages DNA, but it does so chemically. It does so with a chemical reaction. And the cancer cells that are damaged in this way, when they replicate their DNA, which they need to do to divide, they can't do that because their DNA is damaged, and therefore they die. Temozolomide is a systemic treatment. What that means is that it enters, you take it orally, it enters your blood, and it travels to all of the cells in the body through the bloodstream. However, it has a preference. Its effect is bigger on cancer cells than it is on normal cells, and this is for a couple of reasons. One of the reasons is that, as I mentioned, this temozolomide, it damages DNA so that it blocks the cell from dividing, and it causes the dividing cell to die. Cancer cells, they divide much more than normal cells, so this naturally makes them more susceptible to this kind of damage, because your normal cells, they don't divide as quickly. But also normal cells, because they tend to divide at a much slower rate, they also have more time to repair any damage that temozolomide might cause them. So they are, to some extent, they're protected from the toxic effect of temozolomide. But this is a very relative thing, because actually temozolomide does affect normal cells too, and because of that, it can cause several side effects. And with regards to the temozolomide side effect, the most common ones are nausea, fatigue, so quite similar actually to radiotherapy. But one thing that it can cause sort of gastrointestinal upset in the form of diarrhea or constipation. And probably the most important side effect of temozolomide is that it can cause low blood cell counts. And that's why most patients who have this treatment, they usually also get they take antibiotics during the temozolomide treatment to help prevent any infections that might arise because of the low blood cell count, and they have to be monitored, so they have to have regular blood tests. There are some more serious side effects, which, however, are fortunately very uncommon. These include liver, lung, and kidney damage. But NICE says that these are extremely rare side effects. So the severe lung, liver, or kidney side effects that that basically are so severe that cause patients to have to stop temozolomide, they are very rare, in the order of 1 in 10,000. So one patient out of 10,000 people on temozolomide have a side effect that is that serious, according to the UK statistics. I briefly wanted to mention MGMT just because I know that many of you will have heard this when you spoke about glioblastoma with your doctor. And basically, MGMT is a built-in mechanism that cancer cells have to repair their own DNA. MGMT is an enzyme that fixes the chemical damage that is caused by temozolomide. And glioblastoma can either have methylated MGMT or unmethylated MGMT. Glioblastomas that have methylated MGMT means that they do not produce this enzyme, or they do not produce it at a high level, and therefore they are less able to fix DNA, the damage to DNA. This makes them more susceptible to, or more responsive to, treatment, and therefore usually patients with methylated MGMT, they respond to chemotherapy a little bit better. This contrasts with unmethylated MGMT, which means that the tumor cells produce this enzyme that fixes the DNA damage caused by the chemotherapy. And therefore, these cells are less sensitive to the chemotherapy. Patients with this kind of tumor, their response is less. That doesn't mean they don't respond, because temozolomide has still been shown to have benefit even in patients who do not have who have unmethylated MGMT, but the benefit is a bit less. That being said, it should be noted that even cancers that do not have MGMT and therefore cannot fix DNA, they may develop that ability over time, or they may have alternative strategies to cope with the damage that the chemotherapy induces. So a cancer that has methylated MGMT and therefore cannot fix the DNA in this way, it can still use other ways to fix DNA. So the current main problems with the current treatment is that, first of all, glioblastoma cells blend very well into the surrounding brain, and even with even using the fluorescent dye, this means that the cells can never be fully removed with surgery. There's always some cells which are left behind. Secondly, there are some glioblastomas that show very little to no response to treatment, and this is known as intrinsic resistance. They do not respond to radiotherapy or chemotherapy. Finally, there are also some glioblastomas that initially shrink with treatment, but then they stop shrinking and they start growing again. This is known as acquired resistance. So because of these problems with the current standard of care, there has been a lot of research over the past 20 years in finding alternative treatments to glioblastoma. And probably one of the most promising ones is tumor treating fields. Tumor treating fields are alternating electrical fields, which are produced by a device called Optune, and they are delivered to the tumor in the brain using adhesive patches, adhesive electrodes that are applied to the skin on the head. These electrical fields disrupt division of cancer cells, and therefore they slow tumor growth. This treatment has lots of advantages. First of all, it's non-invasive. This does not the electrodes are placed on your scalp. There's no surgery involved. And secondly, it's also a very well-tolerated treatment. So there are very few side effects. The main side effect is skin irritation at the site where the electrodes are placed. And then it's also a portable treatment. So the Optune device shown here, it's the whole kit weighs about 1.5 kilograms, maybe a bit less. It's a portable kit, so you don't have to stay in hospital to have this treatment, and therefore it is in that way it's very convenient. it has also shown some efficacy, because trials have shown that it does prolong survival by about 5 months, and it also improves quality of life to some extent. So it's not just does it increase survival a bit, but it also increases the quality of that survival. The disadvantages to this treatment, the main issues are that not every patient responds. Secondly, when the tumor comes back, when the cancer recurs, it is less effective. So in recurrent glioblastoma, the efficacy is much less than it is in newly diagnosed cancer. And the third main drawback is its significant costs. Because of that, unfortunately, this treatment is not available through the NHS, and it is only available privately in the UK. I'm not sure exactly what the cost is, but I know that there are certain clinics, private clinics, that will refer patients to the company that produces this type of device, and that company provides all of the details regarding costs, and it basically it rents the device for an amount of time at a certain cost. Unfortunately, at the moment, it's not available through the NHS, but in the UK, I think there are some charities that will partially cover the costs, it is something that there's been quite a bit of pressure on the NHS to authorize this treatment, but we're still not at that stage, unfortunately. The other sort of alternative treatment that I wanted to briefly discuss are immunotherapies. And the ones that have been tried in glioblastoma, they can be classified into 4 main types. These include checkpoint inhibitors, vaccines, CAR T-cell therapy, and a combination of different immunotherapies called IMI, or individualized multimodal immunotherapy. So, as you all know, the immune system is designed to help our body fight against bacteria, viruses, parasites, and also internal threats like cancer cells. So it's designed to fight not just external pathogens, but also internal threats that come from our body. Immune cells, they are a bit like weapons designed to face all of these threats, but exactly like weapons, they have sort of a built-in safety mechanism that prevents them from misfiring, and this safety mechanism is referred to as immune checkpoints. They exist naturally on immune cells, and they prevent immune cells from attacking normal cells and misfiring and causing damage when they shouldn't. The problem is that cancer cells take advantage of this safety mechanism, and they turn the safety mechanism on, so they stop the immune cells from firing, in other words. So what the checkpoint inhibitors do is they turn that safety off. They thus unblock immune cells to help them recognize and kill the cancer. Checkpoint inhibitors have had quite a lot of success in treating several cancer types, including skin cancer, lung, colorectal, and renal cancer. And there have been several clinical trials evaluating checkpoint inhibitors in glioblastoma. So the way most of these trials worked was that patients had the standard of care. So they had surgery, then they had radiotherapy with temozolomide, and then they either had temozolomide with temozolomide on its own, or temozolomide with a checkpoint inhibitor, or a checkpoint inhibitor on its own. Or sometimes patients were randomized to a different type of treatment, like bevacizumab, for example. So these trials compared checkpoint inhibitors with either the standard of care or other alternative treatments. Most of the time, most of the trials on checkpoint inhibitors were on recurrent GBM. So they were on, the checkpoint inhibitor was given when the cancer came back. And unfortunately, most of these trials, they did not show a benefit with checkpoint inhibitors. However, relatively recently, there was a trial looking at basically recurrent GBM and at patients who had recurrent cancer that was operable. And what this trial showed was that a checkpoint inhibitor called pembrolizumab can help shrink the tumor prior to surgery, and can improve survival after surgery in this small group of patients who have glioblastoma that comes back and that is still operable. So there may be a role for checkpoint inhibitors in that context. Overall, the results have been rather disappointing, though, mainly because few people respond to this treatment. However, it should be said that those who do respond, they do benefit from this treatment. They are a small group of people, but they do, their survival is affected. More recently, dendritic cell vaccines have been introduced in glioblastoma, and what these are, they're basically, so first of all, dendritic cells are cells that occur naturally. They're part of our immune system, and they monitor the body for any threats, and they activate immune cells to help them basically recognize and fight cancer. What these dendritic cell vaccines are, they're made of dendritic cells that are taken from the patient, and then they are made with proteins that are obtained from that patient's own tumor. So usually the way these work is the patient has surgery. That surgery removes the tumor. That tumor is broken up. Proteins are extracted from the tumor. The patient has a blood draw. Dendritic cells are isolated from the patient's blood, and they are mixed with these proteins from the tumor. So the dendritic cells are trained in the lab to recognize these tumor-associated proteins. Once they have been trained in the lab, they are injected back into the patient. And in 2022, there was quite a big trial on several hundred glioblastoma patients that showed that a dendritic cell vaccine called DCVax did extend survival in both newly diagnosed glioblastoma and also in recurrent GBM. So the survival benefit was about 3 months in newly diagnosed tumors and over 5 months in recurrent GBM. This was a small breakthrough because it was the first immunotherapy to make a meaningful difference to survival in GBM, especially in recurrent GBM. And the other good thing about this treatment was that it had a very reassuring safety profile. Only 2% of the patients enrolled in this trial had severe side effects. So the vast majority of people had only mild to moderate side effects. This vaccine is now manufactured in the UK, but unfortunately, because of its high cost, it's not available through the NHS. It is only available privately, and the cost is very significant, unfortunately. There is still some research going on in dendritic cell vaccines. In fact, there is a lot of research, partly because while they do extend survival, most of the patients who have these vaccines, they eventually develop resistance to the vaccine. So they respond for a period of time, for about up to 6 months, but then that response stops. So there is still research into that, and there's quite a lot of research into that, actually. Another strategy which is sort of being attempted recently, in recent years, are CAR T cells. And you may have heard CAR T cells because they have had a lot of success in blood cancers. So in certain types of lymphomas, they've really revolutionized the treatment for certain types of blood cancers. And what CAR T cells are, they're basically T cells that they're, again, normal cells that our immune system has, that are engineered in the lab to target the tumor. They directly recognize the cancer cells, and they have the ability to directly kill the cancer cells. Unfortunately, while they've been very successful in some blood cancers, they have been less successful in solid tumors. And the reason why this is because in blood cancers, the cancer cells are sort of free floating in your blood, and they can be kind of taken out one by one individually by these T cells. However, in solid cancers, the cells are the cancer cells stick together, and they create an environment around the tumor that shields the tumor from the immune system. So even if the T cells can kill the tumor, they have in theory, in the lab, when they're injected in the patient, they cannot get past that barrier that shields the tumor in the solid tumor in the patient. Therefore, they've been less effective overall. Recently, there has been a trial with CAR T cells where these have been injected into the ventricles of the brain, into the fluid that cushions the brain, that surrounds the brain, in patients with recurrent glioblastoma. And radiologically, this caused quite dramatic response to treatment. So the tumors shrunk dramatically after this treatment. However, the response only lasted a few months, and we don't have data yet on survival. So this particular trial that was published quite recently in spring of this year, it did show a radiological response, but we're still waiting for data about survival, whether it actually made any difference to survival in these patients. And I should also highlight that this was a very small trial, only 3 patients, so it was very small. In 2 of those patients, the response was dramatic, but as I said, we're still waiting for more data. There is another strategy that is being used to treat glioblastoma, which is a combination of some of the immunotherapies that I've just mentioned. And it's known as individualized multimodal immunotherapy, IMI. It was developed by IOZK, which is a research institute in Germany. And it's a combination of 4 different treatments. These are administered successively, so one after the other in successive cycles. The first one of these is an oncolytic virus. This is basically a virus that infects and kills the glioblastoma cells. The second part of the treatment is something called electrohyperthermia, which is the application of electromagnetic fields to disrupt the growth of the tumor. The third part of this treatment is a DC vaccine, extremely similar to the vaccine that I illustrated before. So it involves a blood draw, training your immune cells to recognize the cancer, and then re-injecting those immune cells into the blood. And finally, the last part is checkpoint inhibitors, so those drugs that unblock the immune system. And this treatment is given with maintenance temozolomide. Now, there have been a few clinical trials on this. What these clinical trials have shown is that this individualized multimodal immunotherapy does not improve survival when it's used on its own. So after the patients had radiotherapy and then had temozolomide, after they had surgery, then radiotherapy with temozolomide, and then they had this treatment on its own, that did not increase their survival. However, when this treatment was added to maintenance temozolomide after radiotherapy, it made an important difference. It really made a difference. So IMI combined with temozolomide significantly improved survival. Here, this is the data that was recently published, yes, quite recently actually, in 2024, where the patients who were on the standard of care, they had a survival of about 13 months, whereas a median survival, those who had standard of care temozolomide plus this treatment had a median overall survival of 22 months. And this IMI worked for both methylated and unmethylated tumors. Both showed a response, with methylated tumors responding more to a bigger extent than unmethylated ones. Also very reassuring aspect is that patients that only had mild to moderate side effects, so only grade 0 to 2, so it was well tolerated overall. These are, of course, very promising results. However, I'd like to highlight a few limitations of this treatment. First of all, the data that we have about IMI, about individualized multimodal immunotherapy, is pretty much based on trials that have been performed at a single research center. These trials were on limited number of patients. We're talking about 20, 30 patients, so not a lot of patients. And most of the data out there is published by authors, by scientists who are affiliated with the research institute who developed this treatment. So the results are promising. I'm certainly not denying that, but there are some limitations, and we do not have big clinical trials that corroborate this data. Really, we only have pretty small trials based at a single research center. The other things to keep in mind is that it is only available privately, partly because it is expensive and there isn't enough data out there. So the costs are about, 2 cycles last about 5 weeks. The costs are around £60,000. And also it works best when if it is planned preoperatively, because the way this treatment works is that the vaccine is developed using your own tumor cells. So for the treatment to be developed, the people who develop the vaccine for you need to have access to your tumor material. So patients have to travel to the research center in Germany. They have a consultation with a doctor there where they plan the treatment. They have surgery, and then the tumor obtained during surgery is used to make that vaccine and to plan the next stages of treatment. So, in summary, the pros and cons of immunotherapy are, well, first of all, the pros of immunotherapy are that it is very specific. So it targets the tumor in a rather specific way, and because of that, it tends to have fewer side effects than compared to a chemotherapy, which is a much less specific treatment approach. It therefore has quite a good side effect profile, and the immunotherapy offers the opportunity to provide personalized treatment. You can immunotherapy allows us to get the patient's cells, tumor cells, their immune cells, to train them or to modify them to attack that patient's own tumor. So it's a very customized treatment approach. Some immunotherapies, especially dendritic cell vaccines and the combined immunotherapy approach, have had some promising results. And in theory, what the immune system has is that other treatments do not have is memory. Your immune system is already trained to remember the bacteria, the viruses, the cancer cells that it has encountered in the past. So when you stimulate an immune response against your cancer, the immune system generates memory cells that should, at least in theory, be able to remember that cancer and stop that cancer from coming back in the future. This is in theory. In practice, it's not quite like that, and I'll explain why later. The cons to immunotherapy are that not everyone responds, and even those who do respond, they at some point stop responding. It is quite costly, and it is difficult to access for various reasons. And for some treatments, there is still very limited data. So what are the barriers to developing successful treatments in GBM? There are lots of barriers, but I think that there are 5 things that are really hampering the development of new treatments. And I think that, first of all, the location of the tumor in the brain in such a vital area is a big limitation, because the surgeon cannot just go and cut out the tumor, because that would cause a lot of damage to the neural networks that surround the cancer. So the location is definitely a big challenge. Secondly, the brain is surrounded by a protective barrier that's called the blood-brain barrier. That is what the reason it has this barrier is it's a barrier that stops potentially harmful substances in the blood from entering the brain. The problem is that it also stops a lot of drugs from entering the brain. So getting drugs to enter into the brain across this barrier is difficult. The other aspect that makes it so difficult to treat is something called heterogeneity, and I will explain briefly what that means later in just a moment. The fourth aspect is the very suppressive environment around the tumor. So GBM is very well shielded from the immune system, and that makes it very difficult to treat with immunotherapy, for example. But another thing that I think scientists are really struggling with right now are the preclinical models. In glioblastoma, there is a common theme that you see in all of the research nowadays, which is that you have some drugs that work really well in our animal models. So there are drugs that where almost 90% you give them to mice, and almost 90% of the mice will respond very well to that drug. But then when you try that drug, when you use it in human hosts, in patients, you don't see that level of response. So our preclinical models are clearly flawed. There is an issue that we have poor preclinical models that do not accurately represent the disease in real life. And it's really hard to create a clinical model, because it is the brain is such a complex area that creating a building of the environment of the brain in the lab is virtually impossible. And the brain is in no way the same as the brain of a human being. There are lots of factors there. So that's something that I think is hampering research quite a lot. Going to heterogeneity, I just sort of wanted to explain what this means. Heterogeneity means, what it means in very simple terms is that glioblastoma is a tumor that is made up is not made up of the same many different copies or many copies of the same cell. It's not many copies of the same cell. It's made up of lots of cells that are slightly different one from the other. So if you think here on the left we have, let's say this on the left represents glioblastoma at diagnosis. Each circle is a cell, and all of these cells, they are sensitive to chemotherapy or radiotherapy or both. In other words, they will die when you are exposed to radiotherapy or temozolomide. The only exception being the red cells. The red cell is the resistant, what are referred to as the chemo-radio-resistant cells. The first step, we said, is surgery. Surgery gets rid of most of these cells, but a few inevitably are left behind. After that, the patient undergoes radiotherapy and chemotherapy, and that kills off most of the remaining cells. However, what that radiotherapy and chemotherapy do is they create create an evolutionary pressure. So they can get rid of the remaining cells, but not the resistant cells. Over time, those resistant cells take over the tumor. They start dividing, and the tumor comes back. And as you can see, the recurrent tumor, the tumor that comes back maybe a year later, is very different from the tumor. This tumor on the right, the recurrent tumor, is very different from the tumor on the left, the original tumor. So one thing that people often compare this to is the evolutionary pressure of a mass extinction event. So if you think, if the tumor, let's say the tumor at diagnosis is the world when dinosaurs were around and where only a few mammals were existed, the treatment is the meteor that kills off all of the dinosaurs and destroys almost every form of life. But there are a few mammals out there that survive that meteor. Over millions of years, those mammals reproduce, evolve, and you end up with the world as we know it today. So, which is very different from how it was. Cancer is really very much like that. It's evolution, and the treatment that we give to cancer is an evolutionary pressure that forces the tumor to evolve rapidly, and that's why at the end the tumor is so difficult to treat, because we have effectively eliminated all of the sensitive, of the weak cells, and the only cells that are left are the strong cells that are resistant to the treatments that we have. So in terms of the immunosuppressive environment of the tumor, what I just want to highlight is that in glioblastoma, it's been shown that people who have a lot of immune cells in their tumor actually do a bit worse than people who do not have immune cells or have a lower level of immune cells. And this is a bit of a surprise or counterintuitive in some ways, because you would think that the immune system helps kill the cancer. In glioblastoma, this does not seem to be the case. In fact, it seems that the immune system around the tumor is actually helping the tumor. And what this has sort of led to the belief that GBM hijacks immune cells to actually help support tumor growth. And we now know that immune cells, they support tumor growth in at least 3 ways. They provide growth stimuli to the cells, so they stimulate the cell to grow. They provide oxygen and nutrients to these cells, for example, by stimulating the growth of blood vessels to the tumor. And also they stop other immune cells from doing their job, from identifying and killing the cancer. So they create that shield that I was talking about earlier. And I'll promise I'm almost done. I apologize. I know this has been quite long, but the current research on glioblastoma is focusing on a number of areas. One of these areas are so-called cancer stem cells, and the idea behind this research theme is that not every cell in glioblastoma is equally important. So experiments have shown that there are some cells in glioblastoma that are extremely resistant to treatment and that have a very high, a very very strong ability, let's say, to divide. And there are some cells that are actually not good at dividing at all. They're quite they don't even form tumors when they are separated from the main tumor and for example cultured in vitro. So the idea behind this research is the question is there a way to find the cells that actually are more important, that drive that drive cell division and drive tumor growth and kill those cells. If you think of it, it's a bit like researchers are thinking about this type of cancer a bit like a plant, where you have some cells that are the roots of the plant and the tumor, which is the trunk and the branches. This kind of research is trying to target the roots of the plant to try and eradicate the tumor altogether, because it is thought that these cells, these stem cells, are driving resistance to treatment, they're driving recurrence, they're also driving the heterogeneity of the tumor. So they give rise to lots of different cells. And the idea is targeting these cells is actually more important than targeting all of the cells, because not all of the cells are actually important. The other aspect of is targeting the immunosuppressive environment. So finding ways to make this environment less immunosuppressive and more amenable to immunotherapies. And this is what I am dealing with. This is where my work sort of lies. The other aspect of research nowadays has to do with drug delivery systems, and there's been with the development of nanorobotics and nanoparticles, there has been a lot of progress in developing strategies to deliver deliver drugs through that blood-brain barrier to the tumor. Because as I said, one of the issues is that the blood-brain barrier shields the tumor from the rest of the body. But nowadays there are clinical trials and preclinical studies on strategies, on nanoparticles that can deliver drugs more effectively to the tumor. There are also other areas of research that are looking at the metabolism of the tumor. The glioblastoma cells, basically they use energy in a very different way from normal cells. And researchers are trying to understand whether that very different way of using energy, whether that is something that can be targeted to kill the cancer. And finally, there are quite a number of targeted drugs that target specific pathways inside the cancer cells, things like STAT3 inhibitors or receptor tyrosine kinase inhibitors, which are being researched. Now, these cancer cells, they don't just rely on one pathway to survive. They rely on many different processes. Lots of parts of the cellular machinery are modified to support the cell. So a single drug is almost certainly never going to work. One single inhibitor will not work on its own. That's why it is now what we're seeing is there is an increased tendency to try drug combinations, so inhibitors with, for example, immunotherapies together, or inhibitors, targeted drugs with other targeted drugs. So that's kind of where we are at the moment in terms of research. In summary, to recapitulate everything that I've said, the key points that I wanted to convey are that the current standard of care is based on surgery, radiotherapy, and temozolomide. Among the alternative treatments, tumor treating fields, and immunotherapies, especially dendritic cell vaccines and individualized multimodal immunotherapy, combinatorial immunotherapies, have shown promise, but their availability is limited either by their high cost or by the limited data that is available. The barriers to success in treating glioblastoma include the location of the tumor, the blood-brain barrier, the fact that the tumor is made of lots of different cells that behave slightly differently from one another, the environment of the tumor, and the fact that we have poor preclinical models on which to base our research. So that's my sort of summary of the current treatments and research on glioblastoma. I know this has gone on for a lot of time. There was quite a lot of material to cover. I thank you very much for your attention, and I would now very much like to know about what your questions and comments, and I'd like to sort of have you lead the discussion now, if that's all right.
Yeah, I just wanted to chip in and say thank you so much for that, Daniel. You asked ahead of time if people might need a break, and I didn't consider whether you might need a break because you were speaking uninterrupted for an hour. So I'm sorry if that was too much, but thank you so much for that. Yeah, we've got some hands up, and there was a message in the chat, so I'll just field questions. And of course, people feel free to stay as long as they can. Daniel, you know, if you've got a time that you have to get off by as well, but I'm here as long as we have Daniel. So
I don't have a time, but I know people do have time, do have to.
Yeah.
So I can, please, if you have to go, of course, go.
Of course,
I'm
yeah.
sorry it took so long, but I hope that it was somewhat useful. Although I realize that a lot of things you may know much more than I do, because I'm sure that a lot of you have a lot of knowledge around this. So thanks for your patience.
Absolutely, yeah, agreed. So I'll just start with the question that we had first, which was from it's not showing me who it's from. Richard. So the question was, has the fluorescent dye now been rolled out as part of standard of care surgery? When he had his surgery in 2022, it wasn't available as standard.
So whether it is so now it is the standard. So it is the standard of care right now. Fluorescence guided neurosurgical resection is the what is recommended in all in the UK, because it's been shown to improve the extent of resection and improve the outcomes after surgery. So it is. Right now, it is the recommended treatment.
Well, thank you, Daniel. We'll go up to Grant now. He's had his hand up.
Daniel, thank you very much, and an amazing presentation, really helpful. Quick question to you. You covered IOZK as immunotherapy treatments, but you didn't cover CGAT. You mentioned DCVax as well. Any reason? Because CGAT have also published their results. I know it's not scientifically, I'll use the word valid because I don't know what the right word is, but it was their own results published by themselves about what's happening. Have you got any observations about CGAT versus IOZK?
Are you talking about the dendritic cell vaccine?
Yeah. Yes. So CGAT is Saskia. Can't remember her surname. Have you come across them?
So I'll be honest, I haven't come across that. I know that there are a few other aside from IOZK and DCLVax, there are a few other dendritic cell vaccines that are that are out there. But I'll be honest with you, Grant. I haven't come across that one in particular.
Okay.
There is. I have at the end in my references. So actually, Brains Trust has a very good website that has probably you know it has all of the where it lists a lot of the alternative treatments. I'm not sure. I'm not. I'll be honest. I'm not sure about that one specifically, whether that's included there. But what have you read about that?
No, I've done the first stage of it, which is DNA mapping.
Oh, I see. Okay.
So they can actually identify which genes have mutated. And in my case, 2 inhibitor genes. So I was just wondering, because obviously the next stage is do you go ahead? And I won't ask for any advice here, but just for everyone else's sake, I haven't had any regrowth in 2 years. And it was quite interesting, your colored bubbles of what a tumor looks like.
Mhm.
So between 3 years ago and now, I suspect I've got some strange red bubble that is not indicative of what the DNA analysis was. So yeah, so a bit of wait and see, I think, is the answer.
And sorry, Grant, just to clarify, you said the tumor hasn't grown in 2 years. Is that on on immunotherapy or on no treatment?
No, on just standard of care.
On standard of care.
Sorry, and as you can possibly see, I've got Optune as well, TTF.
Okay.
Which I'm sure has a huge impact on us.
Yeah, yeah.
Thank you.
Thank you. Please feel free to ask any questions. I think there are. Susan has some questions. Hi, Susan.
Yes, I do. Yes, I do. You haven't mentioned proton beam therapy for recurrence.
Proton beam therapy, yes. So that is also out there. Yes, I didn't mention that partly because of time constraints. I didn't want it to. But yes, it is true that is out there. I'll be honest, I'm not an expert on that, so I do not know much about it. But do you have any information about that you'd like to share?
Well, I did. I'm an oncology dietitian, and I did some work at a private radiotherapy centre, which was providing proton beam, and we had patients with recurrent brain tumours. Obviously, you can only have radiotherapy, standard radiotherapy, in one area, and they had fairly good results from proton beam. But of course, there's only 2 proton beam machines in the UK. So if anybody wants it, they either have to go to America or Germany.
And forgive me, Susan, is this something that is does the NHS cover it at all, or is it private?
Yes, there's a proton beam machine in Christie in Manchester and in UCH in London.
Yeah, we wrote up a series of little books, I guess, explaining the landscape and the difference and comparing proton beam to photon. And things like that, because I think when we first started getting it in the UK, there were a lot of question about whether it's I guess, like a superior thing to photon therapy.
I don't think it's superior from what I understand.
No, it's just
I think
it's just a better choice for some people,
line.
isn't it?
Yeah, but it's a good something to have if you've had, like my daughter's had the protons.
Yeah.
She's had the photons. So she could have the option of protons, but she wouldn't have it in this country. She'd have to go abroad for it.
That's it, yeah. Thank you, Susan.
I'll actually read into that, Susan. Thank you because I have heard of that and I have come across that, but I haven't delved into it. So I will read into that. Thank you for that.
Oh, you're welcome. Thank you.
Yeah, I can share a link to our books on photon and proton therapies as well afterwards with everybody by email as well. Are there any more questions for Danielle, or if you want to put them in the chat or raise hands or anything? Richard?
Richard, I believe your microphone is...
Yeah, sorry.
I can hear you now.
The proton beam, is that the same as irradiation therapy? Is that different?
It's protons, and it's protons instead of photons, so it's different beams.
Yeah. Yes. I asked because it was something. I went through standard of care, and as I was coming to the end of that treatment, there was a couple of options should it not have been successful. One was further surgery and also irradiation therapy, but I sort of hear you can only have one round of radiotherapy and things like that. So I wondered whether it was, when I sort of Google it, I know we're not it often references proton, but it mentions all other things as well. But that's okay.
I think that's, I mean, I only know this to say a bit for my daughter and a little bit about where I work, where I used to work. So, because there are literally no proton beam machines in the UK, the standard care is photons.
Mm-hmm.
But you can, as I say, you can go abroad for your protons.
Okay.
There was 3 proton beam centres private. They were Rutherford cancer centres, and they all shut down overnight in June 2022.
Thank you for that, Susan, for your insights. Sophie?
I wanted to ask about IDH inhibitors, which I guess is more relevant for people with IDH mutated tumors. But given the Indigo study showed such good results for grade 2s, but I was wondering what your perspective was on IDH inhibitors in higher grade tumors.
So it's a very good question. I'm not an expert on IDH1 mutant tumors. They're quite they are quite different from the wild type tumors in clinical behavior, and in even genetically and metabolically speaking. But what I can say is that there is increasing evidence that from a research perspective that IDH isn't just a metabolic enzyme. It's not just something involved in metabolism. It's actually probably a gene that is that has a role in the oncogenesis, in the actual initiation of the tumor, and it affects not so it doesn't just affect the metabolism of the tumor. It affects the gene expression of the tumor. It affects even the immune system around the tumor. It has lots of effects on the immune cells as well. So there is a lot of research now into IDH1 in and IDH2 actually in higher grade tumors, because it's thought to have a role that is much more important than we initially thought. So there is, I know there is research on that. I don't know where we are in terms of clinical trials, in terms of for high grade tumors. So I'm sorry, I'm not very informed on that, but I do know that there is a lot of research on in IDH1, because the evidence is that it's actually a driver of the cancer, rather than just being a mutation that happens with cancer. It's actually driving lots of cancer-associated processes, so there is research into that in America, especially.
Thank you, Daniel.
Thank you.
Did you have a question, Helen, or you put your hand down?
Well, I think I sort of know the answer. Is the whichever photon, proton, is one of those also known as gamma knife? Gamma knife radiotherapy, because it's more precise. Is that something different again?
It's something different again. It's probably best to ask your oncologist about that.
It's not relevant for me at this moment in time, but I know I've heard about gamma knife.
Mm-hmm. Yeah, I think Susan is right. I think it's a separate form of treatment.
Yes. I've had to look it up, because I wasn't sure myself, but I think it's a different form of radiotherapy, I believe.
Mm-hmm.
And I'm glad to hear that the 5-ALA is now standard of care everywhere, because I know when I had it, I think not every hospital, I think it was one of these postcode lottery things still when I had it. Yeah. Luckily, I was in a hospital that did, but I was sure that it wasn't everywhere at the time.
That's right. Yeah. Thank you, Alan.
it really makes a difference. I think it really makes a difference. Although it's not foolproof. It doesn't work perfectly, but it does make a big difference. And I think it has made a difference over the past few years. The fact that it's been adopted widely now. Probably should have happened earlier, but things take time to be implemented, unfortunately, and yeah, but I completely agree.
Richard?
Thank you very much. I'm going to have to go and get ready for work now, so thank you.
Thanks so much for joining, Helen.
Okay, nice to see you, Adam.
Nice to
Thank
see you. Talk to you
Bye.
soon.
Thanks. So I was just shows a couple of things. I've got a friend that had gamma knife treatment, but that was for a benign tumour. So hospital where I was treated, it depends on, but I think obviously that's more for Helen. The question I had was obviously doing research. Well, within the GBM community, there's a lot of discussions around alternate treatments. Now, I might get one of these wrong, but I think lion's mane, is that a mushroom? People are making it into a tea and doing, things like that. Now, I didn't myself. My oncologist said only to do what she told me to do, which I did. I trusted her. She was very good. There is a patient in Nottingham who there's fair confidence that it was those alternative therapies on top of, she wasn't able to have surgery. She had radiotherapy and it made her extremely poorly, let's say. Her and her daughter supplemented that with some alternate therapies. She's now walking and talking as I am.
Mm-hmm.
And at the time, she needed 24-hour care. She was in a wheelchair and she got no, she couldn't talk.
I think it's
sorry, Adam, can I just say something? Do apologise. I'm doing a webinar on the 14th of November on nutrition.
Yeah.
And I will include lion's mane for you.
Yeah. I've got some thoughts and comments too, but I'll let you go first, Daniel.
Well, no, I was about to say that it's hard. I don't know how much data there is in support of this. Probably Susan knows more than I do because I'm not in no way an expert on nutrition. There are I know that I do remember reading about some trials where certain nutritional supplements had been included and they didn't show they hadn't shown an effect on the tumor per se. There's also been so things like even certain in terms of because of the metabolism of the tumor, certain drugs that are thought to act on the metabolism of the tumor have been tried, like even metformin, for example, and that I know did not show a benefit. In fact, patients on metformin actually did worse than those who were just on the standard of care. So I think that part of that, I think that yes, there are a lot of those things out there. I don't know how much data there is, but I know that some of them have been tried and they haven't been very successful. I don't know the details, but I have come across a few trials where they tried nutritional supplements on top of normal therapy, and they weren't successful in terms of treating the tumor per se. That doesn't mean though that they may have had effects on the patient that were very positive and that perhaps were not measurable on the scan or on they may very well have effects on patients that we cannot measure clinically, but that are still significant. So I think that's worth thinking about.
Yeah, I've got another one.
Yes.
This is also something that that comes up and has been, I think, depending on where you're treated, and it seems to be more country rather than just in the UK, is on the standard of care, the timing of the temozolomide as well. That I'm just sharing information, Daniele, hoping it's useful. Now, I was advised to take my temozolomide mid-morning, so specified morning. Most effective then. That was obviously it fitted when I was having radiotherapy because that was my appointments were always around lunchtime. But the same advice when I was on the chemotherapy alone cycle. Some people have been told to take it at night because it makes them feel sick. Therefore, it's better to have it when you're asleep. But there's mixed things. You know, I was told that time for a reason, but other people have been told different times. So I thought it was just an interesting one to throw in the mix.
May I ask, Richard, were you advised to take temozolomide on an empty stomach or with food?
Yes, had to be on an empty stomach.
Empty stomach. That's what I
no,
thought too.
Yeah,
Or that's
no 2 no food 2 hours before, no food 2 hours after. So that's what drove me mid-morning.
Understood.
But it was specified morning as well. So it's empty stomach and during the morning.
My daughter's being treated at Marsden, and hers is always the evening.
Oh.
But she takes a Keppra. She takes a Keppra at the same time as well. So she takes a cocktail at 10:15.
That's interesting. All mine I took as other than the chemotherapy in the morning.
Well, she takes a Keppra obviously every 12 hours, so 10:15 a.m. and 10:15 p.m. and then she would take her Temo at 10:15 at night.
Yeah, my husband Liam's also at the Marsden, and he takes his in the evening.
Interesting. Do we have any... Oh, sorry, go on, Daniel.
Oh no, I actually kind of had a question for everyone, and in that I was wondering what your experience was with getting recruited to clinical trials. Was it easy? Was it difficult? How was that experience for you as patients?
I can say that. Oh, sorry, Richard, you go first.
That's okay. I was just being polite. You go ahead, Denise.
No, I'm talking about my partner, but so you go first.
Okay. So yes, I mean, I other than the ALA5, I don't think they take it in the morning. That was just an advice. I wasn't on any clinical trials, but I was told if SOC hadn't worked, then they would be looking at them and offering them. And that was in Weston Park in Sheffield. So, yeah, I felt that I had access to trials if there were any suitable ones, no problem at all. I didn't have to ask, they were being offered if needed.
You were lucky.
I've been very, very lucky in the treatment I've had at Weston Park. They've been fantastic.
I found it impossible to get any information about clinical trials. I'm a professional person. I'm really pushy. I will ask questions that people don't want me to ask. And I got absolutely nowhere. That they just were not interested, whether it was lack of time, lack of resources, lack of education. And this is at Christie's in Manchester. I don't know, but that was my experience.
So it seems very variable depending on perhaps where you are, and right. That's my impression, at least from what I've heard from you and from some other patients that I've spoken to. That it really depends on where you are in the country.
Yeah.
But is it education?
We're delighted that my daughter doesn't have access to clinical trials at the moment because her disease is stable. So I think that's but her oncologist has assured her that if the time comes, then he will introduce her, because she asked questions. There's that piece of work that was done at UCH, wasn't there? And it was all in the press about the man who was an inoperable glioblastoma. Is it Richard? What's the name of the doctor in UCH? And he's done something which is a bit off the wall, and the man's still alive. So my daughter spoke to her oncologist, and he said, well, to be honest with you, you were diagnosed before that man, and you're still alive, and you're doing really well. So I think it's interesting to sort of temper, if you're well with no active disease, you don't need a trial. And
But there are lots of people who might want access to trials, and I personally, my personal feeling is it's educating the medical professionals, it's educating the public so that they know to ask the questions about trials, and giving the public resources so they know where to find out about those trials. And also, as well as education, I think it's the medical professionals having the time or having a leaflet to hand over to the patients to say, hey, look on this website for medical trials that might be available. I don't know what the answer is to that.
Yeah, I mean, I think the charities do as much as we can to make sure that people are signposted, but it's a case with a lot of elements where it should be that first point of contact, where everyone gets everything they need.
Yeah, absolutely. It should be in the pack that you get.
You're right. You've got your hand up, Sarah.
Just to reinforce that, really, we're trying to sort of explore the clinical trial area, and we're finding it really hard to navigate. And it's very much the message from the Marsden today was, it's only if your tumour, you've come to the end of SOC and it's a reoccurrence of your tumour, that's the only time that you'll then be offered any sort of access to trials, which just feels so counterproductive, that you want to be getting to the thing before it's not responsive to anything else. You want to, getting it under control before it's out of control.
Yeah. I'll share along with everything else I already said that I would the photon books and the we've got like a novel therapies page and things like that. But we also have a connection to an organization called My Tomorrows that some of you might have heard of before. And we've got like an active partnership with them now, and they have patient navigators that help you specifically find clinical trials. So they do all the legwork for you. You just have a conversation with them, and they find if anything's available. So I'll share a link to that as well.
But it's knowing that they exist at that entry point, isn't it? And I raised that on that conference actually, that how do you educate? Because this is, for me, this is the biggest problem, is educating people that exists in the first place, because medical professionals might not have the time, they might not know about it, but if I know about it, I can poke them till they do something, or I can phone them up myself, can't I? So that's fantastic, Adam.
Yeah, you are completely right. Tom?
Just to briefly come to clinical trials, there'd be a problem getting an ethical approval for a trial that was, withholding standard of care versus a new treatment, because that would be, you're withholding standard of care that is shown to be effective to something compared to something which may or may not be effective, and that is going to be a challenge to get approval for, because unless you would have to be very, very specific in what you told the potential participants about the risks, and that's a challenge most people are not going to take on, because that's why it's much more straightforward. If you've had standard care and it's no longer working, then you can run the trial because you're not depriving somebody of something.
Yeah, absolutely, Tom. Thank you. Sophie?
Yeah, maybe just one point to add. We recently sought a second opinion in the US with regards to the IDH inhibitors, which I understand is not relevant to people with a wild type tumor. But one of the interesting points that we kind of got out of that discussion is whilst and IDH inhibitor is just one example of the kind of drug that we could possibly access off-label or off-license, or via an alternative means, not as part of standard of care. There could be other things like the checkpoint inhibitors that have been mentioned today, along with some other immunotherapies, etc. But actually doing that at this point, when there is no clinical need, i.e. no recurrence yet, may be counterproductive, because there's not enough evidence to really make a evidence-based decision to go into any of these routes. And choosing a route, therefore, is kind of your best guess, but it can't be an evidence-based decision at this point. But actually, it may be counterproductive in the future, because it may exclude us from eligibility of future clinical trials, because once you have been exposed to an agent of your choice, I guess, it then is no longer an independent variable. So if you were to meet the eligibility criteria of a study, you then don't have the option at that point. So I just thought that was an interesting perspective that we hadn't really considered at that point.
Yeah, absolutely. And again, it just goes back to Carrie's point. Like we don't know these things until afterwards. It's information that everybody should have, really. Tom?
Yeah, we touched on molecular stuff, and I just was curious as to if Danielle knew for all the GBM patients, how many of them would have had their genetic profile of their tumor made? I mean, would that be 1%, or I just don't know. I would like to know a bit more about genetic profiling, because you need the genetic profile, and then you can find a drug that's used for something else that can be targeted at that. And I just wondered, I have no good feel myself as to how common genetic profiling is, and should not every patient have this done, because then you then have that piece of information which may get you quicker access to trials that work in it.
Yeah, absolutely. Do you have any thoughts on that, Danielle?
So from what I know, a DNA profiling isn't done to everyone as a following surgery, unless, so it's not, from what I know, it's not done automatically. It's not the
definitely not
profiling,
done automatically, and definitely not done automatically.
It's not done automatically. No.
Maybe Adam, it's something we could look just to get a bit more information on.
Yeah, absolutely. I mean, I know that there are, I don't know if it's a trial necessarily, but there's a project in, I think it's Cambridge, I think, that they're basically starting to develop a process to test what that framework would look like if patients could have it done, and how quickly we can get that information turned around, and how quickly that could then translate into finding out which alternative therapies would most effectively treat people. And that's the whole aim of genetic profiling, is to help your specialists understand what would work best for you. So that's happening. It is happening in the UK, but it's a part of a small project just to kind of test it out. And the aim is to perfect it in one place and then prove that it can work and then roll it out. I don't know what the time frame on that is, but it is something that's happening and there's progress there. And as far as I know, it's going well. But
I think it is. I think it is absolutely an avenue worth pursuing, and that I think has a lot of potential in terms of stratifying patients. Because one of the things that I think that I hope I made clear, and you know very well too, is glioblastoma is a very heterogeneous disease. Patients, the tumor is very different from patient to patient. A treatment, a single treatment, does not fit everyone, and having genetic information on the tumor is I think could be useful in targeting the treatment and understanding what treatment fits best that a particular patient. Of course, the issue with glioblastoma is that it's there isn't just heterogeneity between patients; it's also within the tumor. So a lot of the time, the genetic information it's still very useful, but it doesn't. Of course, that doesn't it's still very difficult to treat, and the rates of resistance are very high, but I do think that it's a very promising avenue, and I do hope that in the future treatments will be guided by genetic data, increasingly by genetic data. I think I really hope that will happen soon. I absolutely, I'm very much a supporter of that.
Mm-hmm. I think as well, like, it can be done privately, obviously, in different countries if people have the means. I can't remember off the top of my head what that is, or what those locations are. But I know that patients have talked to us about having had that done in other places as well.
It may not always necessarily. So the issue is that of course there are also limited treatment options right now for glioblastoma, and while we can sequence a tumor and we can get a lot of information from it, that may not necessarily have an impact in terms of treatment right now, just because the options are quite limited, and even when a mutation is detected, it may not, a lot of the time that it's not a targetable mutation right now, because we just don't have the means to target that mutation. We can detect it, and we can sequence very quickly and very effectively nowadays, but I think a lot of the mutations that we know are recurrent in glioblastoma and we think are driving the disease, we still cannot target them well, and we can't target them well for various reasons. One, because the drugs that we do have that we can target, that can target that mutation, we can't get them to the right place, or when we do get them at the right place, we find that they're not effective because the cancer switches to a different mutation. It's even with that genetic information, I don't know if right now, because the treatment avenues are limited, I think that genetic information will be very important as the field progresses and as more targeted treatments become available. Right now, I think it may not make a big difference in terms of what treatments you actually end up having, because we just don't have the ability to target a lot of those mutations. Which, one thing that I wanted to quickly say also is that I do feel like the perhaps, and you may disagree with me with this, because I look at it from a different perspective as a doctor, but I do think that sometimes the clinical trials, the way they're structured, it can be a bit rigid, and they may lack flexibility, in that in most cases, as you've mentioned, clinical trials will become accessible only in the context of recurrent glioblastoma, in patients when other options have been completely exhausted, but for example, with checkpoint inhibitors, some trials have shown that if used in certain ways, for example, in the context of recurrent disease that is resectable, they may actually make a big difference. But you need, I think you do need more trials to evaluate these treatments not just at the not just at the very end after all of the treatments have been tried and have failed, but also perhaps in combination with the current treatments at different stages. I think that, so especially since with immunotherapy, a lot of immunotherapies they're relatively well tolerated, and I think that there is the possibility, there would be the chance to introduce these perhaps earlier on, or to see if there is a benefit at earlier stages rather than at the very end, when the disease is very resistant. So I think that having more trials like that, looking at combinations of standard of care with alternative treatments rather than just alternative treatments when the standard of care has failed as the last option, I think that could potentially help us understand. I think that could help this field move forward a little bit. But again, it's easier said than done. But perhaps I do think there could be more flexibility in the way these trials are designed, in also the legal framework that governs these trials. I think it is quite rigid at the moment, and perhaps that is a little bit of a barrier as well.
Yeah, I think a lot of people feel like that in the space right now. We do hear that a lot, to be honest, Daniel. Yeah. Denise?
I was just going to ask what is the genetic information? I'm not sure if I'm misunderstanding. Is that if you find out if it's unmethylated or methylated, or I thought that was part of the diagnosis, so I was a little bit confused.
So yes, the methylation status is one thing, although the methylation status is valuable for prognostic purposes, in that it will give you an idea of what the prognosis is, and how much you're likely to benefit from the treatment, or how much you will benefit. But that being said, even patients with an unmethylated MGMT, they're still given temozolomide. They still do have exactly the same treatment as those with methylated MGMT in this country and in most countries, because again, there isn't really much of an alternative, and MGM and temozolomide, even though it works better in methylated tumors, there is some evidence to suggest that it does have that people, even with people who have methylated tumors, unmethylated tumors could still benefit. So it doesn't guide treatment really. The methylation status, the treatment is the same for either methylated or unmethylated. The things that the sequencing can tell us are whether, so there are certain mutations that are more common in certain types of glioblastoma, like for example, amplification of a gene called EGFR, or loss of PTEN. They're called, basically they are mutations in oncogenes or tumor suppressor genes that have a higher prevalence in glioblastoma compared to other cancers. And I think that what those mutations can tell you, they can tell you whether you basically what pathways are more active in your cancer. So perhaps when we will have targeted treatments available, more targeted treatments available, what those mutations can tell you is whether you're likely to respond to that targeted treatment that will target that pathway or that combination of pathways. Because if you have a mutation that makes you resistant to that basically a mutation where your tumor grows with that, not through that pathway but through a different pathway, then there will be no point in offering you a targeted inhibitor of that pathway, because we will know from your mutation profile that your tumor is driven by a different pathway. So we need to, you will be you will respond to a different drug. But this I think the whole sequencing part has an importance when we talk about targeted treatments. When we talk about treatments that target that are highly targeted, perhaps it makes less of a difference, I think, in terms of the current treatments that are widely available. So in that way, the mutations, the mutational profile is useful in the context of targeted treatment. I would say that that's the main use of it.
Thank you, Danielle. So I think it may be time to wrap up. It's been a really, really interesting conversation, and I'd like to thank everyone for staying longer as well to get the most that we could out of this discussion. And thank you so much, Daniel, for lending your time as well to talk to us about this and go through this all with us, because I think I speak for everyone when it's rare to get an opportunity to talk to someone who has that insight and has your level of expertise in this for an uninterrupted amount of time. So it's very valuable. We're really grateful for that. I don't know if there are any final thoughts other than just thank yous to everyone for being here. Cool.
Thank you to everyone. I'd like to say that I'm first of all, I've learned a lot of things from you, and so I thank you for taking part. And I would like to say that also that I'd like to apologize in a way that I know I do know some things about brain cancer, but I'm very ignorant on other aspects, and so I'm sorry that perhaps I wasn't able to answer all of the questions, but all of your questions were very good, and I'm just sorry that on certain themes I'm perhaps less well prepared than others, but I very much look forward to talking to you again in the future, and updating you on my research and getting to know more about you and your journeys. I really I'm in debt to all of you today, and thank you so much for giving me this opportunity. This has been really great. Thanks to everyone, really, to Brains Trust and to the patients who've been all of you who've been so great today and patient and insightful. You've contributed so much to this meeting.
Thanks, Danielle.
Thank you so
much.
And
thanks to Adam as well for setting it up.
Of course. Absolutely. Thank you all for being here too. Yeah, I think, Daniel, it's okay. I think there's no one person that has all the answers for everything, but when we all get together, everyone learns a little bit more and is a little bit more informed. I think everyone can say that today, so I'm really grateful for that as well. I'll follow up to everyone with a brief write-up of the things that I said I'd share links to and things like that. And should we need to meet again, Daniel, for more insight, I know you wanted to meet with a group to have some more specific discussion around things that you're actually looking into as part of your PhD in research. I'll make sure that everyone that's here is invited along, has an opportunity to do that if that's the case in the future too.
Thank you. Thank you for teaching me a lot of things today, and thanks a lot for your time.
Thank you all so much.
Thanks,
enjoy
everyone.
your evenings.
Good to see you.
Speak soon.
Thank you.